I am the executive director for the Laura Crandall Brown Foundation. We've been in existence for a little over 7 years, and we do focus on research, awareness, and support services centered around gynecologic cancers. So really in this presentation, it's going to be our goal to cover several things. Some basic information about gynecologic cancers, some tie-ins to the public health perspective, hopefully, and then some information about what our organization does, and then Cheryl's going to provide sort of the personal perspective as she can kind of tie it all together, having been involved with our organization for a while, as well as being an ovarian cancer survivor. So there are 5 types of GYN cancers. Technically, there's a 6th for fallopian tube cancer, but it's very rare. So these are generally the 5 that are talked about, and so you see they relate to the different areas of the reproductive system for women. All women are at risk for GYN cancers, and risk just increases with age. And each is really unique with different signs, symptoms, and risk factors, as well as prevention strategies. But this year, more than 100,000 women will be diagnosed, and more than 30,000 will die. And typically, for almost all of the GYN cancers, other than cervical, we lack effective screening tools for early detection. So just some basic information. Uterine cancer is the most common, with just over 50,000 cases diagnosed annually. Ovarian cancer is the most deadly, typically because, and the hardest to detect. It's typically diagnosed in stage 3 or later, which unfortunately makes patient outcomes not as positive. And then cervical, vulvar, and vaginal cancers are all HPV related. So now with the advent of HPV vaccines, those cancers have seen a large decrease in incidence, thankfully, and are considered almost completely preventable, especially in the younger generations who can be vaccinated early before they're exposed to HPV. In Alabama, we are top 5 for cervical and ovarian deaths, and just the rural nature of our state, as well as just not having, GYN oncology is a specialty, and so not having that many throughout the state, it can be hard for women in rural areas, or if you live in an area that's not geographically close to Birmingham or Mobile, one of the more, or Huntsville, a more metropolitan area, it can be difficult to access a GYN oncologist. These are some of the symptom chart that we usually give out. So you can see the symptoms vary as depending on the GYN cancer. We have this chart on one of our takeaways if you'd like to take it. I don't want to spend a lot of time on this because this is not really the focus of this presentation, but we always say, know your body, know what's normal for you. If you experience abnormal symptoms like this for 10 days or longer, go see your doctor. So first, I really just want to cover, we're really going to focus on ovarian cancer, uterine cancer, and cervical cancer, because those are the most common, those are the ones that affect the most people, and not that vulvar and vaginal cancers aren't important, but just for the sake of time, as well as the public health perspective for cervical cancer is very much relatable for those vulvar and vaginal cancers because they are caused by HPV most of the time, just like cervical cancer. But first, we'll cover ovarian cancer. So annually, there are about 20,000 women diagnosed in the U.S., and about 15,000 will die. That's not necessarily the same people, obviously. It causes more deaths than any other GYN cancer, and it's the 5th leading cause of cancer deaths among women. 1 in 73 women will be diagnosed, and if diagnosed early, the survival rate is very good. It's 92%, but unfortunately, only 15% of cases are diagnosed at this early stage. 85% are typically diagnosed in stage 3 or later, which unfortunately means the survival rate is right at 50%, if not a little lower. The risks for ovarian cancer vary. These are some of them. Typical ovarian cancer patient is typically white, middle-aged or older. These are the other cancers that they found a family history connection with, as well as Jewish if you have an Ashkenazi Jewish background, your risk goes up. So obviously, if you have one or more of these risks, that doesn't necessarily mean that you would get ovarian cancer, but we like to inform people about them regardless. So as far as public health priorities go for ovarian cancer, the biggest issue with this cancer is that there is no early detection test. So, women who are diagnosed, because it's typically found in stages 3 and later, the prognosis is poor, and doctors have to focus on how to prolong their life with treatment rather than it's not considered typically curable, although I shouldn't say that because there are certainly people who have been diagnosed with stage 3 disease that have no evidence of disease. But it just underscores the importance of finding an early detection tool. So I've sort of tried to outline some of these priorities. If it's in black, our organization focuses on it specifically. So our research focus is early detection of ovarian cancer. We feel like that's the most game-changing area that we could focus on because so many women's lives would be changed if we could detect it early. The other areas of research, obviously here at UAB, there is a great division of GYN oncology here. They focus a lot on treatment options that can prolong women's lives, oral chemos that can have greater flexibility for women and fewer side effects than necessarily coming into the hospital for an infusion. And then there's a lot of research going on nowadays about genomics, the genetic ties that could be predictive factors for ovarian cancer, and/or genomic information that can help come up with more individualized and personalized treatments that can be more effective as everybody's disease is different. As far as awareness, advocacy, and patient support, we push really heavily for awareness education on the signs and symptoms of ovarian cancer, particularly in the face of a lack of screening. One of the barriers that I would say I personally feel like we face is that because this disease is not something that affects as many people as, say, breast cancer or a more common cancer that affects women, we get a little bit of pushback, I would say, from, putting awareness information in like your typical OBGYN's office. They don't want to scare their patients. Some of the symptoms for ovarian cancer can be very subtle and easily attributed to a much more common, GI cause or something like that. And so, it's just a fine balance that we're trying to strike between ensuring that we are educating people and they know the signs and symptoms, and, making sure that everybody who wakes up with feeling bloated doesn't assume that they have ovarian cancer. So we're still trying to build really good relationships with healthcare providers in the community to ensure that we can strike that correct balance. We also advocate for oral chemotherapy parity. As more oral chemo options are developed, some patients experience issues with being able to pay for those, because typically if you go to the hospital for an infusion, that's covered under your medical benefit for your health insurance, whereas many times the oral chemotherapy is covered under your prescription benefit. So the cost out of pocket can be astronomically higher for oral chemo. And obviously we advocate that patients and their doctors should be able to decide what treatment is best for them and not have to worry about those sort of astronomical costs just because one of them is covered under a prescription benefit versus medical. One of the things that we stress after we talk about the signs and symptoms is if you or anyone you know is ever diagnosed with a GYN cancer, please go see a GYN oncologist. So not a medical oncologist, not your general practitioner, not a general surgeon, but a GYN oncologist, because they are trained specially to deal with the surgery and all of the intricacies that go into treating someone with a GYN cancer. And so research shows that women who see a GYN oncologist have much greater health outcomes than women who don't. So then uterine cancer is the next GYN cancer I wanted to just cover briefly. It is the most common GYN cancer, with 50,000 women annually diagnosed, about 9,000 will die. It's the fourth most common cancer in women, but it is fortunately usually found early. The symptoms are more blatant typically, and so women do usually go in, and it's usually found early and is considered highly curable. So the 5-year survival rate is much improved over ovarian cancer at about 82%. The risks, obesity, high blood pressure, and diabetes, as well as being older than 50, hormone therapy, infertility, a family history of some other cancers, and then tamoxifen, which is a breast cancer drug, has actually been identified as a risk factor as well. So again, these are not necessarily indications that someone's going to get uterine cancer, but they are proven risk factors. As with ovarian cancer, there is no early detection test for uterine cancer. It's not as much of an issue necessarily because it's not considered as deadly, but I mean, people are dying from uterine cancer, so I would say for us, it's definitely still an issue. So we don't fund uterine cancer research specifically. Our focus is solely on the early detection of ovarian cancer. But there is research out there, trying to focus on that, as well as what I spoke about earlier as far as genomics and predictive factors that can be identified with that, as well as more personalized treatments that can be created through genomics. Again, we push for awareness of signs and symptoms because there's a lack of screening. There's also increased racial disparity for uterine cancer. African American women typically are diagnosed later, and the death rate is significantly higher than for white women with uterine cancer. And so promoting access to regular GYN healthcare, particularly for African Americans and persons in general with of low socioeconomic status. And then again, access to GYN oncologists is going to be a persistent issue for all of these cancers that we talk about. So then cervical cancer may be the one that most people have heard of, along with ovarian cancer. The rates for this have dropped dramatically over the years, obviously because we have the pap smear. So this is the one GYN cancer that we do have an early detection test for. That is the pap smear. Right now, annually, about 12,000 women are diagnosed with cervical cancer, and 4,000 will die. It is caused by the human papillomavirus, or HPV, which is a really common virus passed from person to person through sexual activity. It's estimated that 50 to 85% of the population will be infected with it at some point. Most people are able to just flush it from their system with no other effects. We don't know why some people it turns into cervical cancer where it doesn't with others. But they have identified that as almost the sole cause of cervical cancer and the cause of 40 to 70% of vulvar and vaginal cancers. So it's highly treatable when it's found early, and it's often found early thanks to the pap smear test. And then now considered almost completely preventable in the younger generation due to the HPV vaccine. Risks include smoking, HIV, and long-term use of birth control, as well as having multiple sexual partners. And just to clarify, that is strictly because multiple sexual partners increases your risk or your likelihood of acquiring HPV, which increases your risk for cervical cancer. So for cervical cancer, the pap test is the early detection tool that is used. It detects cell changes on the cervix that might become cancer if they're not treated. Typically, women and girls between the ages of 21 and 65. Of course, the recommendations have changed a lot recently with pap smear. We're not going to get into that, but go see your OBGYN regularly, and she can tell you how often you should get your pap smear. The HPV test is also now part of preventive and early detection testing, just because if you do test positive for HPV, that can affect the recommendation that your doctor's going to make as far as how often you should get a pap smear. As far as prevention goes, we do have the HPV vaccines, which, you know, in the cancer community, as far as working for a cancer organization, we often are so much focused on, well, find a cure, and that's wonderful, but in my opinion, this is like the next best thing. Like if you can't find a cure, if you can find a way to prevent it with a vaccine, like that's an incredible step in progress. Unfortunately, with the HPV vaccine, it's the most refused vaccine out there, which we'll talk about a little bit more later. This is just some general information about it. Given as a series of 3 shots, although recent research has shown that one dose can be just as effective as all 3. These are the ages that they are recommending it for. Basically, you just want girls and boys to get it before they reach that age where they could become sexually active and be exposed to HPV. But women still need to go get regular pap tests, regardless of whether they've had the HPV vaccine or not. I think the largest public health priority in this area is to increase vaccine uptake. Right now, estimates hover around 30 to 40% as far as the number of adolescents in this age group that are actually getting this vaccine. And there's not a lot of definitive research as to why people aren't getting it. One of the best guesses is that physicians aren't recommending it strongly enough, and that parents are receiving a lot of misinformation about it. So it has been proven and tested in widespread studies that featured 250,000 patients to be very safe and reliable. And unfortunately, there's been a lot of anecdotal evidence put out there. You know, you can read anything on Facebook or social media or online. It's like, I'm pregnant, and I learned the first time I was pregnant, don't Google anything, because you will find something that you don't want to read, and it may not be true. But with this, there's a lot of misinformation out there about the safety and efficacy. This is a very safe and effective vaccine, and so we are focused on trying to get funding right now for a education program that would focus on educating physicians on how important their recommendation to parents is, so that the adolescents get vaccinated. As far as the other areas, awareness, advocacy, and patient support, you know, advocating for integration into school vaccination requirements. We haven't focused on that as much in Alabama, just because you want to spend your money and time where it's most likely to have an impact, and it's not necessarily an area that we think we could have an impact at this time, unfortunately. As with uterine cancer, there are some racial disparities as well with cervical cancer, women being diagnosed later and the death rate being higher amongst African Americans and minorities versus white women. And then again, the access to GYN oncologists and emphasis on that being important is something that needs to be emphasized regardless of GYN cancer. So this is our mission and vision, and I won't read it to you because you're graduate students, so you can read. But we were founded in 2009 after the death of Laura Crandall Brown, who was a young woman diagnosed with ovarian cancer at the age of 25. And she unfortunately was diagnosed in the later stages and passed away after about a 14-month battle. So she had always expressed the desire to help other people who would be faced with her same situation, and that's really where the foundation started. And it started with just the research focus. So early detection of ovarian cancer, how can we be a game changer there to ensure that women in the future can get diagnosed earlier and live longer. Over the past couple years, as the foundation has grown, we've added two other program areas. So As far as research goes, we do provide innovative seed grants. Typically, $50,000 to $100,000 is the amount that we're going to give out, and we're looking to fund. You know, the NIH is already out there funding huge studies. We're looking to fund the more innovative strategies that we can provide them with the money to get successful preliminary data that they need to then go leverage that into the NIH funding at levels, 20 times above what we provided and higher. So that's pretty much what our research focus is, and we've had some good success with that so far. As far as awareness goes, we do have a statewide speakers bureau. This is an example of what we would do with that, and we also set up awareness booths at various corporate, civic, women's fairs, health fairs, just to spread the awareness education. And then we have a State of Teal, which is our lighting initiative. I don't know if you guys saw any buildings lit teal during the month of September, which is GYN Cancer Awareness Month, but we light typically 100 to 130 buildings throughout the state in teal just to highlight that September is GYN Cancer Awareness Month, and the importance of knowing the signs and symptoms of those cancers. We also have a support program for patients who are going through treatment or who have just women who have had a GYN cancer, as well as their family members and loved ones. Healthcare providers participate, and that provides emotional and educational support, as well as some direct financial support. So we help women if they need assistance with transportation to get to treatment, if they need some basic needs assistance. We provide patient bags for women who have just started treatment. There's a variety of ways that we help out that in that area. And then the support group provides 2 meetings a month. And like I said, those are some of the areas that we try to help women going through treatment directly, to really lift them up so they don't, cancer is already a very chaotic thing to go through. So as much as we can, try to help them, lift them up out of the chaos of that. That's what the support group is for. So now I want to turn it over to Cheryl. She is the chair of our Can Survive support group, and she's also an ovarian cancer survivor, and so she's very familiar with the organization and our programs, and can tell you why it's important to her.
When I was listening to Marianne, and she was talking about the HPV vaccine too. Y'all have heard of herd immunity before, right? So I know in Australia the vaccine rates are a lot higher there, and so they're really finding a great decrease in HPV already. And so when she was talking about people being able to post on Facebook, about, you don't need to get vaccinated because, you might get autism or, have seizures or whatever. One of those comments can undo lots of education. So what we're looking for there is good herd immunity to protect everybody. And although males do not get cervical cancer, they can get cancer of the throat from HPV and that kind of thing. So that's why that's really important. I wanted to make sure I told y'all that.
And penile and anal cancer as well.
Yes. So anyway, it's just good to be protected. And I do a lot of awareness talks and speak to mothers. And when it first came out, they said, no, that's sexually transmitted. And I said, well, don't you figure your child will be sexually active at one time? Don't you want them to get married and all that? Wouldn't you want to prevent something you could prevent? And so we found a lot of resistance when we first started talking to everybody about that. But now I find that more and more women are getting their kids vaccinated. So I'm really excited about that. As far as a personal perspective, I wanted to tell you that cancer doesn't just run in my family, it gallops. And so I had a sister that had early stage breast cancer at the age of 36. I had 2 aunts on my dad's side, great aunts on my dad's side that had breast cancer. I had my paternal aunt had breast cancer at 34. My mother died of pancreatic cancer. My grandmother had, on my dad's side, had colon cancer. My grandfather on my dad's side had bladder and lung cancer. So in my family, it wasn't, I am so sorry, sinuses. In my family, it wasn't if we would get cancer, but when. So when I was 51, which was 11 years ago, I ended up having symptoms that I never associated with cancer, despite all that cancer in my family. And it was interesting because I had lots of fatigue. Now, I had a kid who was in college, and he was, I'm trying to help him get his first apartment. I'm going to all the garage sales. I have a mother-in-law and a stepmother-in-law that I'm helping with activities of daily living, and I'm exhausted. But who wouldn't be exhausted, doing all that stuff? And then, I was getting older. I figured that was part of it. I never associated the fatigue with that I might have cancer. I had all my mammograms done all the time. Breast cancer was what ran in my family mostly. But then there were some other things that happened. I got short of breath. I had some persistent bloating. Then it got so bad that I looked about like Marianne does, 8 months pregnant. And when it got to that point, I couldn't ignore it. And I mentioned it to my mail lady, and she said, "You have symptoms of ovarian cancer." I'd never heard the symptoms of ovarian cancer. This was 2005. In 2008, they actually did figure out, they pulled charts from women, and they did figure out that ovarian cancer does have some symptoms. But this was before that. So I went to my regular doctor. He did a CA-125 test, ordered a CT scan, and a colonoscopy. Well, I decided to postpone the colonoscopy, had the other two done first, and it came back as, yes, you probably have ovarian cancer. So I went to the doctor, I got referred quickly to a GYN oncologist, and I had debulking surgery, and then a week later, I started chemo. I had 6 rounds of chemo, and I have not had recurrence. I cannot tell you how unusual it is not to have a recurrence. My cancer was stage 3C, and that's when most cancers are found. So, why do you need to go to a GYN oncologist? GYN oncologists go in, and they're very aggressive when they do their surgery. They really get out every bit of cancer they can see, because they know if you leave anything behind, it's going to spread. And then they pray that the chemo is going to take care of the rest of it. So that's why you don't want to go to a general surgeon for this kind of disease. That's why it's important that our insurance company, the one we have in the state of Alabama, that they refer people to a GYN oncologist if that is suspected. So that's another thing we have been advocating for. So you wonder, well, with all that cancer in my family, I know y'all are going, ding, ding, there's got to be some genetics there. Well, my sister was diagnosed in 1993. If you think about it, BRCA, BRCA mutations weren't discovered until around that time. And they weren't clinically applicable until later in the 1990s, 2000. So, and even then, when they became in vogue, we wouldn't have met the testing rubric. Today we would have. My sister would have been tested right then because of her early age breast cancer and because of my aunt's age. Well, so when I had ovarian cancer, my sister's oncologist said, "We need to check you. Sure enough, we have a BRCA mutation in my family, and it's in 4 generations of our family." So that accounts for 10 to 15% of cases of ovarian cancer, and it's not that prevalent in the population, but when you have that history in your family, that you become suspicious. So why is that important in the public health setting? We need to make sure that people have access to this. If these kinds of diseases run in their family. They need to be able to access a genetics counselor and what that means. Today, I probably should not have even told you I had a BRCA mutation, because even though I cannot be denied health coverage, I could be denied life insurance coverage. So you need to know that kind of thing. Hang on. Let me see if there was anything else. I was trying to make it short and sweet for y'all. And because I have you as a captive audience, I do want to tell you the signs and symptoms of ovarian cancer. You can remember it from beet ovarian. The B is for bloating, that's persistent. The E is for eating and feeling full quicker than you normally would. At the time of, I'm going to go back to that. The A is for abdominal pain or pelvic pain. The T is for trouble with your bladder, got to go more urgently or more frequently, which happens as women age, but it's even more so. So when they pulled all those charts I told you about, they found that women typically had at least one of those symptoms. When you have one of those symptoms, it's often already in the late stage. But we didn't even have anything to go on before that. So that's all we have to go on right now. You could also have abnormal bleeding, back pain, changes in bowel habits, and there's one more, but I can't think. But the beet ovarian is what really makes you remember it.
Or changes in skin color.
But there you go. No, that's something else. That's the other one. But anyway, so I had a lot of those symptoms. I had the bloating. I had the eating and feeling full quickly. At the time of my surgery, they removed 9.5 liters of fluid from my abdomen. That was caused by the cancer. That's not unusual. Usually when I talk to med students, I have 2-liter pop bottles. Can you imagine? Almost 5 2-liter pop bottles of fluid in my abdomen that the cancer caused. So it's a deadly disease. It spreads quickly. It recurs often. So that's what one of the things I wanted you to put a face with ovarian cancer. Since I have been involved with the support group since my diagnosis, I got involved with a support group in 2006. I've personally known over 30 women who've died from ovarian cancer. And I don't meet everybody. We have a very high incidence of that in our state. So we need to find an early screening test, and we need to educate women till then. And Marianne spoke about some of the disparities in care for women in our state. Do y'all know about the Deep South Network? Do you know who Dr. Partridge is? He's over the Comprehensive Cancer Center. He's the director. And about 15 years ago, he started a program in Alabama in the poor rural areas to help women especially be encouraged to go get the proper health care, get mammograms, get pap smears and that kind of thing. And how he did that is he trained women in the communities about how to talk to these people and encourage them to do that, because you're going to believe your neighbor sometimes before somebody that just comes in out of the street. So as far as I know, that program is still in effect. So I just wanted you to be aware, because that's part of this program is why they wanted us to come talk.